expecting more or less that you have not been in practice for quite some times, and psychiatric mental health nursing was actually in your third year. So I think you have forgotten some of the concept. So this is what we are going to do. Now today, I'm going to look on a little bit on the backgrounders of psychiatric nursing. And then tomorrow, we're going to look into the meat. That means to say, we're going to have questions and then rationalization. I really would like that when you're going to take the examination, because this is one of the major parts of your board examination, you're going to be comfortable, and at the same time, you are, you know what you're answering, you know how you answer, and you know the rationality or rationalization of what you are trying to answer in there. Para madaling ipasa ang psychiatric nursing. So I'm going to start with 3 topics today. I do hope that Sander will be sending you. Sander, I sent PDF copies of the PowerPoint.
It has been shared to the group already, Doctor. Don't worry.
More or less, yes, that's a good thing. So right now, by the way, before I'm going to start, I will share with you who am I, because you see, I am Dr. Arnel. I've been teaching in for 30 years in the Philippines, Malaysia, and this year is my 13th year teaching as associate professor at Tarak Medical and Health Sciences University. Basically, I am teaching bachelor's degree, RN-BSN program, and master's degree program. So I am engaged with psychiatry and psychology, since I'm also a clinical psychologist. I have studied in so many schools in the Philippines. I went to UP also. I went to UST also, and so on. I got my clinical psychology degree from the United States. So hopefully you can learn from me. Yeah, let's cross our fingers. And hopefully it will, our session today and tomorrow will add to your confidence in taking your board examination this coming April. Don't worry, it will be very easy. All right, I would like to start with the first lecture. Can we share now? Can all of you see my PowerPoint?
Yes, Doc.
All right. So the first thing that we're going to look today is the nursing care for mentally ill patients. This is actually very basic, but looking into what or how we are going to consider our patients, and at the same time looking into the history. Now, I will start by sharing with you who the founder is of psychiatric nursing. We'll start with Hildegard Piplo. I'm so sure some of you may have forgotten her. And of course, some of you may know her, but at least let's try to look at her background. Hildegard Piplo is a nurse, a single parent, and a clinical psychologist and such. That's the reason why she founded psychiatric nursing. No, she wrote the book called Interpersonal Relations in Nursing. This is very crucial, and this is very important, because in psychiatric nursing, the first tool that we will be using in the care of our patients would be on how we are going to relate with our patient, interrelationship, communication. That's what we call as of now as therapeutic communication. That's the first thing that we have to bear in mind. When you say psychiatric nursing, the first thing that a nurse will do is actually on how she or he is going to use herself or himself, and at the same time, he can use what we call as therapeutic communication. This is actually very crucial and very important. 50% of the job is done when you know already how to communicate with patient therapeutically. It's not very easy. So Hildegard Piplo has a 50-year career in nursing. You know, this is very important when we emphasize her, let's say, experience as a single parent. She raised her daughter as a single parent while pursuing an ambition in clinical psychology. She was, her daughter is, let's say, clinically challenged, as we say. That's the reason why she was encouraged to take another path from a nurse to clinical psychology, then combine the two. She founded psychiatric nursing as such. Now, let us try to look into the role and definition of what psychiatric nurse is. Not everybody can actually become a psychiatric nurse. We should be trained in order to take care of our patients. Now, you see, in the hospital where we are sending our students, sometimes the nurse managers would pull out nurses from other departments. It's not going to work and it will be useless. That's why they already remove psychiatric ward in Safe Hospital in Ras Al Khaimah. All the patients are brought to Al-Amal Hospital in Dubai. You know the reason why? Because when you are going to face a patient, you must be trained. At least you have a training, you have a very good knowledge on how to deal with your patient. Right? Moving on. In order to become a psychiatric nurse in the Philippines, at least you have an experience. Because not all can actually go and study psychiatric nursing in the University of the Philippines, at the UST, or some other schools that offer psychiatric nursing. I believe it's in UP that they offer master in nursing, psychiatric nursing, and at the same time in UST only that they offer psychiatric nursing as such. Because not all of the nurses or most of the nurses are not having degrees in psychiatric nursing. You see, that's the reason why it's already enough for them to have experience in order to practice as a psychiatric nurse. So basically, you should have training in nursing for 4 years. Then actually after that, at least 12 months of field experience before you can consider yourself as a psychiatric nurse. It's not much as long as you're going to be in contact with psychiatric patients, I mean. And of course, other than that, if you want to continue your study, you should have a postgraduate study in psychiatric nursing as such. You may take up master in psychiatric nursing. You may take up clinical psychology as I did. See? So that you can actually be abreast. You should know what is going on in the field of psychology and psychiatry. Right now, psychiatric nursing and psychiatry is evolving. In 2005, they released Diagnostic Statistical Manual with several other classifications that we did not study in the school before. I belong to class 1993 in my bachelor's degree program, so we did not have a Diagnostic Statistical Manual yet. Right now, it's already on its 5th revision, text revised 2 years ago. And that is actually the basis of how we can diagnose our patients. And at the same time, we are using International Classification of Diseases, or the ICD-10. I believe you're very familiar with this because in your system, if you're working in the hospital, in your system, like in the Northern Emirates, we are using WARID system. We utilize WARID to make our diagnosis in the process of coding. See? So the ICD-10 is also the process of diagnosing our mentally ill patients, particularly in Al-Amal Hospital. So I will teach you about that as we go on. So that's how you can become a mental health nurse. You should have experience, you know. So look at this. Less than 30% of nurses are working in mental health settings are specialized in psychiatric nursing. That means to say, 70% of nurses who are working there are not specialists. They may have experience, but they do not have education. I have some, may mga Pilipino tayo na i-recommend ko sa Al-Amal Hospital na nagtatrabaho ngayon. Ang kanyang master's degree ay in business, MBA. But nevertheless, she worked here in Ras Al Khaimah Psychiatric Ward for at least 2 years. So that qualified her to become a psychiatric nurse. That's the reason why we endorsed, when I endorsed her appointment, her employment, yung chief nurse naman doon, nag-agree. Actually, the chief nurse in Alamal Hospital was my student, and most of the managers there were my students. So more or less, they accept my recommendations in there. So right now, she is considering to come and join us to study in our master's degree program. So that's the meaning of it. So if you are going to have experience in psychiatry for at least 12 months, then that can qualify you already to become a psychiatric nurse because you are exposed with psychiatric patients. You should know already how to communicate with them. That's very important and very crucial. Babalik at babalik tayo dito sa communication in the end. That is the main thing that we should do as a nurse. How we are going to use ourselves therapeutically as such. Okay? So we should have a very good competency in psychiatric nursing. Titignan natin yan later on. Here is the emerging role of psychiatric nurse that I would like you to know. Now, we are going to be doing active roles before. As of now, actually, ito pa rin ang pag-iisip ng mga ibang tao. Nurses are assuming passive roles. We are always following what the doctors actually will give us. It should not be the case. Since we know how to take care of our patient, we know how to use therapeutic communication, and we have a very good knowledge on how to use psychotherapeutic intervention, then we can actually assume active role. We can work side by side with the psychiatrists, with the doctors, I mean. So parang equal na lang natin sila. And that should be what we need to do, not only in psychiatric nursing, but in in all hospitals or setup that we are working. Particularly, we should know what to do every single day. In the hospitals, if you're going to imagine the setup in the hospital, yung mga pasyente doon bored. Imagine, parang nakakon sila sa hawla, nakakulong sila sa hawla, as if they have no freedom also. So what are we going to do? We should be very proactive as a psychiatric nurse. Sa Pilipinas, okay lang doon kasi maluwag ang pwesto. Pero at the end of the day, nakakulong pa rin sila. Dito sa Ras Al Khaimah, ganun din. Doon sa Alamal Hospital, the building and the facility is nice. They have no freedom of movement, just the same. So we should actually be very proactive. Alam natin kung paano ang gagawin natin para hindi magmukmuk sa tabi ang mga pasyente, particularly those who are diagnosed with clinical depression. See? Moving on. Now, I would like to emphasize Sapir-Flo's theory of interpersonal relationship. This is the foundation of psychiatric nursing. Lahat ng isasagot natin sa examination must always carry the rationality or rationalization on Sapir-Flo's theory of interpersonal relation. Dapat nating tandaan yan. Ang mga pasyente na wala sa kanilang lugar for a very long time, mga parents nila, mga relatives nila, and in their community. And chances are, when they are in the mental hospital, parang nakakalimutan na sila ng kanilang mga, let's say, loved ones, mga relatives nila. So the first thing that they need is a relationship to people, relationship to professionals, relationship to nurses. Napaka-importante yung mga nurses dito because nurses are always working with the patient. We need to establish therapeutic relationship with the patient for a very long time with your patient in order to trust us. That's the basic thing. So tingnan natin ang dalawang bilog, no? It's called these two circles representing the individuality of the nurse and the patient, and in between, this is like in the Venn diagram, patient and the nurse are going to be connected. Tandaan natin, ang relationship natin sa pasyente is not on the personal level, but on professional level. There must always be a limitations. Ang pasyente, they are always owning us, parang papasok sa circle natin. They own us. They would like to own us. Sometimes mag-aaway-aaway yan. Pagpasok natin, particularly if we are new to the world, if we do not know how to handle, there would be riot in the world, particularly if we are taking care of patients who are, let's say, violent. Yung mga pasyenteng na-diagnose with bipolar disorder or with schizophrenia, that we are going to tackle eventually. So dapat may boundary sila, may boundary ka. That you have to take note of, no? Ang boundary ito is actually dictated by our professional role as a nurse. Kasi may sarili tayong value, we have our own culture, we have our own belief system, we have also our past experiences. That's very crucial. Past experiences, including the patient, when you are going to look into the history of the patient, tandaan natin, always tingnan ninyo ang past experiences, looking or considering what Sigmund Freud actually mentioned. That I'm going to discuss eventually with you later on. And of course, our expectations and preconceived ideas. May mga tayong pinaniniwalaan palagi na ang mga pasyente ay hindi na maaaring gumaling. That is only true with the case of schizophrenia. Tandaan natin, ang mga pasyente sa psychiatric ward or psychiatric hospitals, the basic thing that we need to think about as nurses would be to make it sure that yung pasyente ay kayang alagaan ang kanyang sarili. He can actually take care of himself. Not necessarily going back to pre-morbid condition, pero at least he can be functional. He can take care of himself, he can take a bath, he can cut his nails, among others. Yun ang kwan natin, yun ang susundin. But looking into pre-morbid condition, that is a long way to go. For patients with psychosis, particularly patients with schizophrenia, wala nang kwan yan. Wala nang pag-asang gumaling to pre-morbid state. So ang ating gagawin na lamang ay to make it sure that they can actually live in the community. They can be livable, they can live with the community, they can mingle with the community, at makukontrol nila ang kanilang mga symptoms, particularly yung hallucinations and delusions eventually. That I'm going to teach you on how you are going to deal with that. These are very common cases that we have. Now, in the case of patients naman, may sariling value sila, may konting culture sila, may belief system sila, may past experience sila, and of course, may expectations. So titingnan natin yan. We respect the patient and the patient will respect us. This is very important. Babalikan at babalikan natin ang theory ni Hildegard Piplo when we are going to look into the disease conditions. That I'm going to shortly introduce to you after this introduction. So, ang mental health, may pag-asa. Ang mental health, ang conditions ng ating bansa ay supposed to be regulated by mental health act. In the Philippines, may naipasa na atang kwan. I am not familiar with that right now, but 2 years ago, I heard that the Congress is coming out with mental health law. So kasi may mga karapatan din ng mga pasyenteng may mental health conditions. So we have to take care of them. In Malaysia, it's very, very they take care of their people. Nagturo ako sa Malaysia, kaya I'm very familiar with that. At nakita ko rin ang napakagandang setup ng kanilang mental hospital. So, yung kanilang mga pasyente ay inaalagaan based on the mental health law. So, Mental Health Act in 2001. In the Philippines, mayroon na ata, but it's not yet passed, no? So they are planning to have that. Hopefully, they will have it, no? So wala akong picture ng mental health sa Pilipinas, ng Mandaluyong sa Pilipinas, National Center for Mental Health. I'm actually putting here on the screen the good picture of how mental health hospital is. Ito napakaganda. Tandaan nyo, ang mga pasyente ay dadalhin either under voluntary volition or involuntary. So that i-discuss ko rin sa inyo later on. kung paano dadalhin ang mga pasyente. Now, you cannot make immediate diagnosis of the hospital. That's the reason why there is the mental health hospital in Malaysia is a perfect setup on how to take care of mentally ill patients. May tinatawag tayong receiving unit. So doon, ang mga pasyente ay magmimix. They are going to be observed for 3 weeks. Tandaan natin, we cannot do a definitive diagnosis in a single day. We need to have a close observations. At tandaan natin, ang mga symptoms ng mga iba't ibang diseases ay always overlapping. Particularly in the case of bipolar disorder and schizophrenia. They have both hallucination, they have both delusion. How we can actually make differential diagnosis when we are going to look at this condition. So it needs to have a very close observation at least for 3 weeks. After 3 weeks that they stayed in receiving unit, they will be distributed to specific wards that take care of specific conditions. In yung sa Pilipinas, mga different pavilions. Dito sa Alamal Hospital, we have only divided them into 4. So for women, for alcoholism, we call that as substance use disorder, and then those with psychotic disorders, see, among others. Okay, so that's that. Then after that, there is another setup which we call a halfway house. Yung mga pasyenteng hindi na diagnose ng schizophrenia, maaring magamot sila. They will recover eventually, and they need to live in the society, in the community. So titira sila doon sa halfway house, doon din sa compound mismo ng mental hospital. Doon maaring tumira ang mga relatives, particularly the close relatives like the parents or brothers or sisters, at doon natin tuturuan ang mga pasyenteng magtrabaho. So inside there is a factory. Most of the time, I believe if you're working in the hospitals, pag nakikita natin yung guantes na blue, made in Malaysia, yun ay gawa ng mga may sakit. Yung mga nakakonfine dito sa Tanjung Rambutan as we call it, no? So gawa yun. So when they're ready, then they can actually be released in the society. That will be it. And chances of relapse is actually almost nil, just because they are making it sure that once the patient is actually released in the society, their family members will have to defend them, of course, will have to understand them, no choice. Then of course, the community will also understand and live with them. Kasi ang compromise nito, pag ang isang pasyente ay na-diagnose na may mental illness, pati yung family members nila kinukutya or kinakahiya. So that's the first thing. We have to remove the stigma from there. So that's one of our job. Moving on, I would like to look into the mental health continuum, right? So ito, we are always on the brink, no? We are always on the brink of moving on the other side. Every single day is a process of adaptation. All right, you see, if you're going to look into this continuum, on one side, adaptive, on the other side, maladaptive. We are balancing. We're always doing the balancing act, no? So sa mga taong well-balanced, they may think rationally, they're very logical, realistic, productive, satisfying career, and fulfilled. But once that there is a condition that tip the balance, maaaring ang mga pasyente, maaaring mga tao ay mag-tip on the maladaptive continuum. Lahat tayo niyan. Particularly mga OFWs, no? The most, let's say, most of the time we encounter anxiety or mood disorder, as we know. We just don't know it, no? See, every single day, we are always trying to be very functional. Pero if something bothers us, we will become dysfunctional. It's okay as long as we adapt later on. But yung ating functionality ay affected for 3 days or more, then it will become a pathologic condition. You need to seek professional help. But less than 3 days, you can still, you can still try to adapt by yourself. That's why if you're going to, I'm going to discuss supposed to be anxiety disorders later on. There are actually 4 labels of it. More disorders, also the most common thing that we have would be depression, but there are others. We have the unipolar, we have the bipolar, we have the cyclothymic, we have the dysthymic, among others. So titignan natin yan, no? And then of course there are personality disorders that you know of. The most common that needs hospitalization would be the borderline personality disorder. Pero may mga taong living with us, yung mga mahilig mag-display ng, they would like to become the center of attention, yung mga histrionic, no? May mga antisocial din. Hopefully, I can tackle more on that when we tackle rationalization already. Pero I think sa board examination, they don't take much. They focus more on the most common disease, that is depression and schizophrenia. But nevertheless, at least may idea tayo kung ano ang personality disorder. Mga 2 or 3 questions dito. Siguro they will ask about borderline personality disorder. Ito kasi kailangan ng hospitalization and kailangan ng care. There is also a disease called psychosis. This is an umbrella of diseases. And one of these psychotic disorders is always take note. Hindi na maaring once you're diagnosed with it, hindi ka na maaring bumalik sa pre-morbid condition. And yun ay tinatawag natin schizophrenia. Pero may mga psychosis din na hindi schizophrenia. So we have schizoaffective, schizophreniform, so brief psychotic disorders. Hopefully we'll discuss about that as we go. Okay? If you have questions, you may just butt in. Right. Any questions so far? I cannot move in anymore. Sandra, are you moving or what? Or are you controlling? Yeah.
I'm controlling, doctor, no problem.
This is actually very important also. Now, in understanding the mental health disorder, dapat tandaan natin ang 3 area. This will be used for our diagnosis. We need to make diagnosis. We need to make differential diagnosis also. Now, we cannot just depend on the diagnosis of the doctors. Imagine this. If you are working in Alamal Hospital or in any hospitals here, the first thing that they are going to place in the record would be psychosis, psychotic disorder, nothing else. Then immediately, the first reaction that we do as nurses would be to treat them accordingly. And that's not good. In the process of making diagnosis, we need to consider biological factors. Yun ang parte ng ating anatomy and physiology. May problema sa utak. May problema sa different neurotransmitters that we have in the brain, like acetylcholine, like dopamine, like serotonin. And also, we have to look into the genes. We have to look into the hormones. And we have to look into the brain structure. That's why side by side with neurology, psychiatry is there. Kasi ang mga taong may neurological disorders would display psychotic behaviors. So we have to rule out some problems that we have in the brain. Like for instance, in the case of traumatic brain injury, the DPI. So you have to rule that out before you are actually going to make a definitive diagnosis. Doon papasok ang neurologist, titingnan kung may problema sa structure ng utak. When they found out that there is a problem in the structure of the brain, then more or less, we can go to the psychological factors to make part of complementary diagnosis. And what do we have here? It's very crucial that we are going to look into the early development of a patient. No? Titingnan natin yan in the history. Napaka-importante yan. Kasi may mga concept tayo sa psychology na nag-change sa personality ng isang tao. Like in the controversy of nature and nurture. No? So ang isang tao ba ay nade-develop ang kanyang mental health by way of inherited factors, or ang tao ba ay na-develop ang kanyang personality by way of the people who are living around him. So, titingnan natin yon, no? So, early development or yung treatment ng kanilang parents. You know, violent parents sometimes they think that they breed violent children. Criminal parents can breed criminal children. Psychotic parents can breed psychotic children. That's why it's very important that we are going to look into the history as much or as far as you can. Then the personality traits. That's why we need to closely observe the patient. That's why also, at least for a period of 21 days, we need to have a very close monitoring and close observation before we can actually make a definitive diagnosis of our cases. So titingnan din natin ang poor parenting. This is one of the crucial factors. And then the childhood trauma that the patient may experience. So ito ang personal component na titingnan natin. So in the process of making diagnosis, titingnan natin to. In the process of treating the patient and doing nursing intervention, titingnan natin to lahat. Kaya mahirap naman yung pag nagsagot tayo sa examination without knowing this, napakahirap intindihin ang case natin. Alright? Then sociocultural factors, the influence of the community to the patient. Ito ang napaka-importante. The belief system, the religious influences. That's the reason why in United Arab Emirates, makikita mo na ang mga taong maaring nagkaroon ng mental health problems, pupunta sila sa kanilang imam. May mga gagamot din sila. Because they believe that the mental health problems could be caused by jinni, something like that, no? Or, there could be inadequate parenting. In this case, there could be unemployment. Maraming, whether you will like it or not, siguro maraming magtataka kayo that in UAE, may mga unemployment. Punta kayo sa Ras Al Khaimah, makikita ninyo. Maraming taong ayaw magtrabaho, particularly those who serve in the military already. That's why most of the time, I have seen so many cases of patients who are confined in Al-Mal Hospital or ex-military. And of course, we have to look into the support system. Okay? Family, friends. So, titingnan natin yan in making the diagnosis of our patients in our case. The moment we'll be able to know the case of our patient, the moment we will be able to look into what cause, maaari nating gamutin yan. Maaari nating mag-design ng nursing intervention and at the same time, therapeutic intervention stuff. So ito yung effect ng influences or factors that affect mental health. As I said, biological aspect, it could be physical health, it could be disability. Physical health, titingnan ninyo, yung mga matatanda, maaaring magkaroon sila ng problems already, no? Sa geriatric condition, Alzheimer's disease, is a psychiatric disorder under cognitive disorder. Tandaan natin yan. So disability also, genetic vulnerability is there. And then social. So I discussed that earlier to you already. That comprises your mental health. Titignan natin ng picture. All right? So moving on with the next slide, Sander. These are the roles of mental health nurses that I would like you to know. No? So for the dependent roles, tandaan natin, generally may dalawang role tayo or may dalawang function na tayo. No? Independent and dependent. Usually ang dependent kailangan natin ng doctor's order. Ang independent, these are the things that we can do without any order coming from the doctors. So for mental health nurses, ang dependent role nila with other team members, in this case the doctors, is on the basis of psychopharmacology that we need to discuss also. I'll discuss with you the interaction between antipsychotic and anxiolytic medication or antidepressants. Titingnan natin yan. So you cannot just give medications without that prescription of the psychiatrist. For our independent role, marami tayong pwedeng gawin dito. maraming mari tayo pwedeng gawin dito, no? So we can actually initiate therapeutic interventions. So I believe nakita ko yung mga estudyante doon sa Pilipinas sa mental hospital, nakakaroon sila ng interpretations of news, music. These are some of the therapeutic interventions that you can actually do, no? You can do assessment, nursing care planning, advocacy, case management, community care, psychoeducation, psychotherapy. That you need to have special training. At least you should know a concept of one concept of psychotherapy as such. Moving on with the next slide. This is how we should work with our patient. Now, client, this will be the center of our activities. It will not be us. Parang yung movie, you know. Client will always be the center of our activities. We should always be working in partnership with our client. Not patronizing approach. You know the meaning of patronizing, you see? Our clients are clients. They should know that they are clients. They should know that there is a limitations, no? Then liberal environment and restrictions. Never I advocated for restrictions. Kaya nga ngayon, yung hindi na yung mga restraints hindi natin ginagamit. Ang mga ginagamit natin ngayon ay yung chemical restraints na tinatawag, yung sedatives. So chemical restraints. But the usual things that the world must be widely open. It should be like that. Liberal environment. They can actually go and watch television. They can walk in the garden. They can do what is supposed to be done as a free person. Kasi dapat nating tandaan na mga pasyente ay hindi parang nakakulong yan just because they committed the crime. Nandun sila sa hospital just because they need help from us. So I would always advocate liberal approach and liberal environment. Then of course, you should know, I do not need to discuss about patient rights. You should know, as a nurse, the different patient's rights, no? And then the equal rights to get good quality care. And of course, as nurse, we should always look into holistic approach, particularly the most difficult is how we are going to connect them with the relatives. Tandaan natin na ang pasyente, once that they are admitted in the hospital, we immediately cut them from their loved ones. Not only in the mental hospital, but in any other hospital, no? So the first problem that we actually have arose would be yung anxiety, then sadness that will develop eventually to depression. So yun ang dapat nating tingnan palagi. We have to look into that as a psychiatric nurse. Moving on with the next slide. Never mind. I would like to emphasize this. This is my book, no? So as a nurse, we need to focus on the following therapeutic interventions. Hopefully I have time to communicate with you about this, no? I wrote the psychology for nurses when I was in Malaysia, you know? Therapeutic touch, simple touch of the patient, I advocate that. But in UAE, do not just do that to your patient. There must always be a limitations. Therapeutic smile and therapeutic use of self. We use this all the time in order to make therapeutic relationship with the patient. Moving on with the next slide, please. These are some of the therapeutic management that we can do as nurses. No, these are independent functions that we can actually do. No, of course we need to establish nurse-patient relationship. You should know the different stages. Okay, and then we can actually do also psychopharmacology. Particularly, we have to take note of biochemical imbalance. Like for instance, the patients who have depression, the first thing that we have to give would be the SSRI, selective serotonin reuptake inhibitors. We have to do that. The only thing that it balances is actually to balance the serotonin that we have in the brain. Then the milieu management that we can always do. Like for instance, in milieu management, milieu means, I believe your teachers know or discuss with you about this when you were in your college. Yun ang napakadali natin gawin, no? For instance, pwede nating kontrolin ang ilaw. If patient is actually depressed, so dapat maliwanag. Yung kurtina dapat full na open at saka yung light. At saka walang music that can actually bring down the mood of the patient. In slow music or depressing music as such. Or we can do a lot. The temperature of the ward, the temperature of the room, we can actually do that, no? And sometimes when the patient affects another patient, so we learn how to remove the patient so that from the room of that particular patient para matone down lang yung kanyang agitations among others. That's Milu management that hopefully you can actually do. Moving on with the next slide, few more slides. So this is what we actually do, no? So Milu management is to develop an atmosphere that facilitates patient growth, rehabilitation, and restoration of health. Basically, i-manipulate natin yung environment ng pasyente para makatulong sa kanyang recovery. Okay? Moving on. Psychotherapy, I understand yung mga teachers natin nung tayo nag-aaral, they introduce some. But of course, these are basing on their experiences. Ang psychotherapy talaga ay pinapag-aralan that there is a special training that you need to do. No? So here, for definition of psychotherapy is the treatment of psychological problems by a professional using specialized tools, no? And verbal technique. That I believe some of us are being taught about this, no? So anyway, there are so many. We will consider individual therapy. We'll consider group therapy that includes family therapy, among others, no? I would like you to know that. Moving on with the next slide. These are some of the psychotherapy that I mentioned earlier. Number of patients, so there could be individual and family. Then underlying principles, like in the case of supportive, reconstructive, re-educative, behavioral. CBT is the most common and the most familiar therapy that we are using. Napakasimple yan. It will be very helpful to those people with mood disorder, like in the case of depression. Yun bang pagsasalamin sa isang tao? Kasi yung mga, alam mo, yung cost ng illness ng pasyente, kaya sila ay na-hospital, is just because they are not looking at themselves. Yung mga behavior nila ay wala na. It's not reflected with them. So what happens is that we mirror them. No? Tayo yung parang mirror, pinapakita natin kung ano ang problema sa pasyente. Then in the end, the patient will change the way he thinks. That is most of the cause of our problem this time. No? The way we think. In order to alleviate our mental, let's say, problems, we need to change the way we think. That's what we want among people, particularly with depression. Depression bordering into crisis, particularly those people who would like to commit suicide already. You see? So we need to reflect. We need to utilize cognitive behavioral therapy that you need to have special training. And of course, it's very important that we have to look into the level of probing into the unconscious mind. It is very important. No? There are things that are not said. There are things that are hidden. These hidden things are the ones that control the behavior of the patient. So, una natin, tingnan yung superficial. As long as we can actually connect with the patient, then eventually we go deep. That is a part of the therapeutic communications that we have to establish, no? When we are already on the working phase. All right? So moving on with the next slide. And these are some of the psychotherapies that I would like to, maybe one question will be asked in the board examination about this. Psychodynamic, the founder of this is Sigmund Freud. We have behavioral therapy. We have also CBT, the most important and the most familiar this time. We have interpersonal therapy. This was the first one advocated by Hildegard Piplo. And of course, in psychology, we have Aristarchus Sulaiman. We have also humanistic therapy, existential therapy. The most famous person here is Viktor Frankl. And then we have therapy that we can normally do as nurses. Group therapy includes family therapy, no? And then of course we have family and marital therapy as such, no? So moving on, I think I will not discuss with you about this, no? So this is supposed to be the flow chart. Now, moving on with the continuum of psychiatric care. Now, this I would like you to know, no? What are the levels of care that we should know with the mental health case, with the psychiatric patients, no? We have hospital-based care. Alam mo, we have also the community-based care, and we have case management. The reason why we need to have hospital-based care is that because the patient is already destructive to themselves and to the other people, and the level of functionality is almost zero. So that's the reason why they need to be cared by psychiatric nurses like us. And in community-based care, when the patient is actually a little bit okay, no? And in setup, like in United Arab Emirates, although we do not visit patients, and the community setup is actually very strong. The primary health care, no, is actually very strong. So, and then of course we have case management. Anyway, it will be. I would tackle this as we go. Moving on with the next line. This is how we do the nursing care delivery system in mental health. No, always we develop and involve partnerships and collaborate with the community. We cannot just stand on our own. As psychiatric nurses, we need to collaborate with the community as such. Of course, how do we collaborate? It's easy. We plan, we initiate, we plan, we monitor, then we evaluate. The cycle is just like that. Like in the normal nursing process that we do. No, we look for a problem, we plan for the interaction, then we evaluate our nursing intervention, then goes to the other circle. The same way in the nursing care delivery system in mental health. Yeah, so moving on. I think this is the last. Now, this is very important. The word deinstitutionalization. No? Ang goal ng psychiatric nurses in the process of care of the patient is to make it sure that ang pasyente will eventually have time to live in the community, matanggal sila sa hospital, so that they can live productively in the community. Tandaan natin yan. It's a long process. Sometimes it may take years, even decades. So, but at least we always have that in mind, that the patient will have time to be living in the community eventually once that they are already well. So that's the goal of psychiatric nursing. Okay? So anyway, I would like to pass through this. So yeah, go on. Next line. Then I think this is a thing we would like to remove our patients from here. Okay? We would like them to live in the community. That's it. So anyway, we go on the nursing, the next topic. And this is actually very important, the level of intervention. Now, in the level of intervention, papasok tayo ngayon doon as individual. No, individual. So we have to look into the individual patients, then family, very important, village, community, and the society. So napakahirap kasi so now we are actually dealing with individual and family alone. Family sometimes are very difficult. So it's actually, there is no chance for recovery. For individual, we do clinical treatment. For family, we do family education. So another one, of course, we do training in the community. That's where our primary health nurses are actually going to work. The primary health nurses or community health nurses, then community, the social works, no, and of course the public policy, the government. Here papasok na yung Mental Health Act or Mental Health Law that can be initiated by Congress in the Philippines. We have that, but I do not know if that's already put into law. So that ends our first lecture, I believe so. So we now go to the next one. Anyway, essential service in the caring system. We pass through that, Sandra. Okay, next slide. Yes. Anyway, all right. So next, we will go to the next topic, lecture number 2.
Okay, Doc, just give me a sec.
Yeah. Hopefully may naintindihan naman kayo. Any reactions? Would you like me to discuss more? At least you have already seen how psychiatric nursing is. No, parang ma-refresh ba sa utak ninyo? Kasi long time back that you studied psychiatric nursing when you were in 3rd year. Yeah. Any questions so far?
If you have questions so far, you can ask your questions now.
Tomorrow tayo magpo-focus sa mga questions, sa tanong. So mag-taking tayo tomorrow.
So we'll go to the second one, Dr. Arnel.
Yes, please, no?
Good afternoon po, Doc.
Hi, good afternoon, Leia.
Yes po. Doc, question ko lang po. Pag mentally ill patient po ba, what is our priority regarding to giving care to them, Doc?
Now, always take note that there must always be the first thing in mind. If the patient is a threat to themselves or a threat to others, are they suicidal? Are they homicidal? Safety ang unang priority natin. Tandaan natin yan. We have to make it sure that they are safe from themselves and they are safe for others also. Yun ang ating tandaan, no? Kaya nga kailangan nating, if there is already a threat, kailangan natin silang tanggalin sa community and admit sa hospital na. So likewise in the hospital, there is what we call as HDU. Ilalagay muna natin sila sa HDU. High dependency. Usually, ang mga psychiatric wards at sa psychiatric hospital, there is what we call as HDU. Doon sila. Okay? At i-observe natin yan. When they're ready again, when they're not threat to themselves and to others, then i-release naman natin. Yan ang ating tandaan muna. You know, in nursing, our main goal is actually to preserve life. Always take note. We cannot remove any signs and symptoms immediately. It will be long term. It will be long time. Pero ang threat to themselves and threat to others, there is always a prevailing problems. These are always a prevailing problem that we have. No? Tandaan natin yan. That's why sometimes we use chemical restraint to our patient. Binibigyan natin siya ng sedative para patulugin muna. Eventually, they will be okay. And that's how we are going to do. Yeah? Did I answer your question, Leah?
Yes po, Doc. Thank you po, Doc. Doc, one last question.
Yes, sige.
Doc, allowed po ba yung mga mentally ill patient natin, Doc, na mag-refuse ng treatment? But by that time, they were okay. Stable po sila by that time. Are they allowed to refuse?
Are they in the hospital or will they be outside the hospital?
In the hospital po, Doc.
In the hospital, they are allowed. By all means, it's the patient right to choose the type of, to choose the treatment. You see? But of course, hindi sila magdidikta kung anong gagawin natin. They can approach psychologists, they can approach psychiatrists, they can approach the nurses. Most of the time, kasi ang ginagawa ng mga psychiatrists, binibigyan lang ng medicine. Ang hospital naman, malaking problema sa mga psychologists na na-employ. Ang pinakamarami talaga doon ay mga nurses, no? Like say in hospital on one shift alone, like in Alamal, maybe 1 or 2 psychologists will be there. So napakahirap. For nurses to take care of patients who are requesting for a specific management or care, we should be really trained. That's the reason why there should always be an ongoing training for nurses to conduct psychotherapy. Ganun yun, no? But they have all the right to request.
Oh, okay po, Doc.
Yeah?
Thank you po, Doc. Yes po, Doc.
All right. Okay. So let's look into the classification of diseases in psychiatric nursing. So i-classify natin yan. Tandaan natin, Sandra, punta ka na lang sa first lesson na. Okay. Yes, sa first one. Tandaan natin, no? Ang psychiatric patients are classified according to their problems. If they are out of touch with reality, if they have problems with their emotions, if they have problems with the foreseeable future, yun ang titignan natin. Then from there, we can actually classify them accordingly. All right? So let's try to move in the first, let's see. So there are three basic purposes of classifying in psychiatry. Understanding, that's comprehension. Then communication and control of data. This is actually very important. We should understand the case of our patient as such. That's the reason why kailangan nating observe sila within 21 days bago tayo magkaroon ng definitive diagnosis. Initially, we can actually come out with initial diagnosis, but this diagnosis will be changed. It depends on how we observe. Of course, communication, how do we communicate with the patient, how we communicate the case of our patients, particularly in the records, then how are we controlling data? You know, for a fact that the data of the patient, once that they are admitted in the hospital, is actually very protective. We can just share it. In an ordinary ward, medical surgical ward, we are not allowed to share much more with psychiatric patients. Okay? Moving forward in the next slide. The purpose of classification actually is to look into the course and prognosis of the disorder. Napaka-importante yung prognosis, yung pagtingin sa prognosis ng disorder. Like for instance, no? Maraming nagkakamali dito yung differentiation ng bipolar disorder at saka schizophrenia. You see? If the patient is actually going to be admitted first with the presenting symptoms of schizophrenia, but that's not actually schizophrenia, it could be a brief psychotic disorder among others. It could be bipolar disorder. Lahat ng mga symptoms ng schizophrenia ay maroon dito. Pag i-diagnose natin ng pasyente ay schizophrenic already, then chances are our treatments to them would be wrong. Chances are we just give medications to control the symptoms. But if we are going to make a very good diagnosis, let's say we diagnose them as bipolar disorder. You know, bipolar disorder belongs to affective disorder or mood disorder. So madaling gamutin yan. Sometimes we do not need pills. We do not need medication. Kailangan lang natin ng psychotherapy. Kailangan lang ng intervention ng psychologist. Or if nurses are trained to do psychotherapy, we can just actually proceed with that. So napaka-importante yan. And one thing more, for bipolar disorders and other disorders aside from schizophrenia, always take note, they can always go back to the pre-morbid state. Ibig sabihin, gagaling 100% if they follow the course of treatment. Pero ang schizophrenia that's under psychosis, hindi na gagaling yan. 100% pa. Kaya pag may na-encounter kayong question na gagaling pa ba ang pasyenteng may schizophrenia, hindi na. Once schizophrenic, they are always going to be schizophrenic. Pero, ano ang dapat nating gawin as nurses? Tandaan natin, we need to improve the level of functionality of patients. Particularly with schizophrenia, kaya na nilang i-take care ng kanilang sarili, kaya na nilang maligong sarili, and they will not be, again, danger to themselves and danger to the society when they are going to be immersed again in the society. Ganon lang yon. Kung tandaan natin, we are always on the lookout for the patients who may actually be homicidal and always suicidal. Yeah. Then of course, the next one, of course, yung control and compilation data and in future research. This is actually very important. It helps in the process of formulation of diagnostic statistical manual text revise. Some of my colleagues in the US have contributed to this, particularly psychologists, clinical psychologists and such. Moving on with the next slide. All right. So, tingnan nyo, on the basis of classification, psychiatric disorders can be classified into the functional disorders and organic disorders. The functionality, ito muna ang i-assess natin. The functionality level, how they can take care of themselves, how they can function in the society. And of course, you know for a fact about organic disorders. Pag ang pasyente ay mayroong organic disorder, napakalaling gamutin yan. Parang yung may sakit ng infection, very easy to treat. Sa antibiotic, specific antibiotic, okay na yun. Pero in functional disorder, sometimes very difficult because you are going to investigate what is really happening to the patient. Right? So the level of functionality, the purpose of treatment for this eventually will be to improve the level of functionality as such. Kaya kailangan natin ng classification accordingly. This. No? All right. Now, the functional disorders can be classified into psychosis and neurosis, as I mentioned to you. No, psychosis. Psychosis is more or less connected to how they perceive reality. No? Okay? So, on reality perception. That the reason why a patient may actually be seeing something, hearing something, they are already out of touch with reality. No, so these are severe forms of psychiatric disorders that need treatment. No, psychosis. No, patients lack insight into the disorder and lose touch with reality. They do not know what's going on. Yung mga taong grasa, they belong to this. Mga taong gasa is they belong to residual disorder, residual schizophrenia. No? So, walang kagalingan yon. Patients also are unable to differentiate between the subjective experiences and external reality. Wala na talaga, hindi na nila ma-distinguish ang reality. Right? That's the reason why sometimes they may display symptoms like delusion. They think that they are Superman. They think that they are great. No, they think that they are God. Or they think that they are Jesus Christ. Okay? And the basic example of psychosis is schizophrenia. Basically, this is a classic example, no? It's schizophrenia. As I mentioned to you earlier, the moment you are diagnosed with this, almost, or no chance at all, 100%, no chance that you will go back to your pre-morbid state. Pero ang goal naman natin dito ay to make it sure that they can live functionally in the community and with their family. Maraming nangyayaring ganyan. So this is what we have in organic disorders also. So functional disorders, to add, we have personality disorders, no? We have also disorders of childhood and adolescence and others. No? In personality disorders, hopefully we can discuss more about this. We have paranoid, schizoid, schizotype, antisocial, borderline, histrionic, narcissistic, avoidant personality disorder, dependent, and OCD. And of course, for children, there could be mental retardation, there could be pervasive developmental disorders. I do not know if our patient with mental retardation in Russell Kama is dead already or was transferred to Alamal Hospital. You know, very, very severe. That her level of functionality is 1 year old. So very dependent. She's old already, but she is very dependent on others. No. And then for organic disorders, we have to look into acute onset, like in the cases of delirium, dementia. Okay? So, next slide, please. So, in the case of neurosis naman, ito ay hindi grabe. It lives among us. It lives with us. We live with them. We have them, in short. No? Mayroon tayo nito every single day. Right? Ang kwan nga lang is na-overcome natin to. It refers to the disorders that are less severe than psychosis. And the symptoms are closer to normal experience. They are basically normal, except when we look into the levels. No? Like in the case of anxiety disorder, we have mild, moderate, severe, and panic attack. Normally, itong dalawang ito, yung severe at saka panic attack, normally kailangan ng hospitalization just because of pre-morbid condition. Kasi nga, there will be some changes that will transpire in your physiology or in your anatomy. Definitely, magkakaroon ng effect sa iyong breathing, sa iyong blood pressure, among others. No? Patients do not lose touch with external reality. They are still in touch with reality. No, very basic. No. So in case of organic disorders, these are disorders in which the history, clinical examination, among others, are based on our anatomy and physiology. There is a problem, basically, in terms of our physiological aspect, like in the case of increased dopamine, in the case of substance use disorder, or decreased serotonin, in the case of depression, among others. No? Okay? So organic disorders may have acute onset or insidious onset. For acute onset, these are disorders which are usually short-lasting and can be treated by removing or treating the cause of disorder. For example, delirium due to diabetes. That can be reversed by controlling the blood sugar level. You know that, no? If there is a sudden increase of blood sugar, so you can control the blood sugar by taking some metformin, among others. No? In the insidious onset, these are quite long-lasting, can be superimposed by acute onset, like in the case of delirium in a patient with dementia. These are all symptoms of some problems that we have in the brain. No, delirium associated with dementia. You know, dementia is a symptom that is most common among patients with Alzheimer's disease. You know for a fact that if you have Alzheimer's disease, there is a decreasing amount of brain physiology and anatomy. Namamatay yung mga cells sa brain natin. So that's why you are encountering dementia, forgetfulness. Okay, as such. Next slide. So these are some of the categories of psychiatric disorders that I would like you to know. The DSM are classifying the disorders based on such following categories. The first one, psychotic disorders. The second one, mood disorder that's related to emotion. The third one, anxiety disorders. The fourth one is personality disorder. It has something to do with how you are perceiving yourself. And then childhood and adolescent disorders. And of course, other disorders, miscellaneous disorders as classified. No? Okay. So the two major disorders, the major disorders can be classified based on ICD, as I mentioned to you earlier. They are developing ICD-11. I think they released already ICD-11, but these are not yet used in the hospitals because we need to overhaul the system the moment we use this in the hospital. The coding that we use in the hospitals are based from ICD-10, including in psychiatry. So internal classification of disease, international classification of diseases. And for us clinical psychologists also, we utilize the Diagnostic Statistical Manual. First released 2005, then it was actually revised so many times. We call it Diagnostic Statistical Manual 5, TR, or text revised. We are including internet addiction, among others in there. Okay? So moving on with the next slide. So the ICD-10 and the DSM-4 or 5 right now is 5 are parallel and compatible with each other, although minor differences in naming of the diagnostic categories and criteria exist. Always, all right, in the ICD, for mental disorders, we use chapter 5. This is going to focus on mental health, mental and behavioral disorders only. But on DSM, entire chapters of DSM are used to classify mental disorders as that's, no? Yung mga bago na didiscover, like in the case of internet addiction, in the later part of the DSM already. They are incorporating also internet addiction in ICD-10. Pero so far wala pa ngayon, no? In terms of Diagnostic Statistical Manual, so this is produced by American Psychiatric Association. This only describes mental disorder. This is actually very important, mind you. I would like to emphasize this, no? Kasi in the Diagnostic Statistical Manual, may definitive description ng mental disorder doon. Like in the case of schizophrenia, so lahat ng mga description doon, 1, 2, 3, 4, 5, maaari mo lamang sabihin ang pasyente ay may schizophrenia if 2 or more of these descriptive symptoms are there with your patients. So that could be one of the definitive diagnosis that we can actually do, right? Remember, in psychiatry and in mental health, it will be very difficult to diagnose the patient. Now, sometimes we judge based on our observation. Walang definite. Hindi natin ipapadala sa kanyan, sa sa pathology department para magkaroon ng diagnosis. We diagnose ourselves. We put our observations, then we place our diagnosis. Okay? All right. Supposed to be this movie. Where are we now? We're done, I think, no? Then the last one.
So next topic na tayo, Dr. Arnel.
Yeah, this is very important right now because I will proceed with the symptoms already. That will be very helpful for tomorrow. The symptoms on mental disorders, no? So, i-club natin later on yung mga questions ng mga estudyante natin.
Wait lang po, Dr. Arnel. We're just shifting the slides.
The third one is actually very important because we need to spot the symptomatology of our patients. And we should learn how to distinguish the different symptoms. Yeah, signs and symptoms of psychiatric disorders. These are actually very essential, no? So, kung may tanong kayo, you may ask questions now or later on. By the way, here is my number also if you want to, no? 056, nandiyan yan. I believe you can actually communicate with me if you want to. All right, so let's proceed now with signs and symptoms of psychiatric disorders. Move on the next slides, no? All right. These are some of the common psychiatric disorders that we have. Anxiety, depression, mania, and the mood disorder. And of course, schizophrenia under psychosis. So these are the things that we always see. Now, anxiety, as I mentioned to you earlier, this is actually very common experience among us. It has something to do with our emotions. And in psychology, we're always telling to our students that this is our primordial emotion, primordial behavior, no? Primordial emotions, primary. This dictates everything on what we are actually going to do. Always, every single day, we are having this. That's why it's very normal. That's the reason why everybody of us do have neurosis. But the level is actually very different. It's okay if you are going to have at least on mild to moderate. Like, for instance, you're late to your job. How do you react? Sometimes it's good because it actually gives us some reason to react and to make some adjustment. That's how we live. And it will not vanish. It will not actually be lost. No. It will always be with us. Like, for instance, if we experience, on the other hand, excessive worrying about almost everything, then that will be a problem because it creates tension within you. Psychological tension is okay as long as it will help us to plan for the future. But if you are threatened by psychological tension every single day, then there will be a problem. Kaya nga nagkakaroon ng problema eventually yung mga pasyente. Excessive worrying will actually lead into something else. Maybe they may actually develop into mood disorder or into psychosis. Mga nababaliw na dahil sa kaiisip ng mga problema, ikangan nila. That's actually a reality. The problema is always there all the time. Problem with our work, personal problem, family problem will always be there. But we're always coming out with those problems because we know how to adjust. In the mental health continuum, we are always adjusting because we are rational. We think all the time. Unahin ang utak bago ang puso. That's how we are always thinking as sane human beings. That's what we do. Anxiety is always there to stay. It becomes disorder the moment you are already inhibited from doing your day-to-day activities or day-to-day tasks. Yung hindi ka na makakain, hindi ka na makatulog, parang sa kanta. But, for a long time, maybe 3 days or more. But for a day also, if you are excited, hindi ka makatulog, it's okay. But if that will last for 3 or more days, then there is a problem already. Excessive happiness also will not be good. You see? So our emotions will go up and down. That's why we call anxiety as a primary or primordial emotions that we have. It dictates things that we need to do every single day. Moving on with the next slide, please. And these are some of the common symptoms of anxiety, no? Feelings of fear or dread. If we are called by the boss, we do not know what's actually going to happen. So sometimes we normally feel fear, no? So what's going on? Am I going to be fired today? Things like that. Physiological manifestation, increased heart rate, tachycardia. There could be palpitations. There could be sweating. The things that I'm discussing already are bordering toward severe anxiety and panic attack. Panic attack is classified under anxiety disorder. This is the fourth level. So these are the four levels of anxiety disorders. Mild, very common, 100% we experience this every single day. Moderate, every single day when we are worrying so much about so many things. That does not cause an alarm as long as you are very functional. And then, of course, we have the severe anxiety. Your functionality is impaired. And then the panic attack, there could always be physiological manifestation, as I mentioned here. Palpitations, sweating, and the heart rate, among others. Now, you have cold and clammy hands also, and the dryness of mouth and your throat. Sometimes you cannot speak. Moving on with the next slide. So there is also difficulty in talking and breathing, then lightheadedness or giddiness, tremor of hands, and you are becoming loosely. These are actually very common, particularly on the third level, that is severe to the panic attack. Yeah. Okay. So for depression, this is classified under mood disorder, right? So major depressive disorder is most closely associated with persistent sadness. Sir, is it okay to be sad? Yes. It's one of the most common emotions that we have. Anxiety, primordial emotion. Sadness is another emotion, although this is negative. Is it okay? Yes. That proves that you are a human being. Now, how you're going to do with it, or what you're going to do with it is actually a challenge. If you are sad for a day, it's okay. But if sadness will persist for 3 days or more, it will impair your daily functionality. I keep on repeating, your daily functionality is affected. You cannot go to your work. You cannot even do your assignment. You cannot even wash your clothes, iron your things. Then there is a problem already. The persistent sadness becomes pathologic in nature. It becomes depression. Of course, there are different classifications for depression. There could be mild, moderate, or severe depression. Severe depression bordering towards clinical depression. So watch out for suicidal ideation in that case. So the most prominent symptom for depression is depressed mode. You know that already. As if, as you do not want to live anymore. There could always be persistent sadness. You cannot even concentrate. Sometimes you question about your self-worth, as if you are useless to your family, to yourselves, and to others. Then sometimes you are crying easily. This is, you are on the watch out because it can bring to, this is always a problem with depression, the feeling of helplessness and hopelessness. So always, the one that follows here will be ideas of suicidal ideation. So, papasok dito yung pasyente sa crisis na. So, doon pupunta. Okay. You may have poor appetite, lack of energy. We call it sometimes anergia. There is social isolation, decreased socialization. There is increased irritability. And then, of course, anhedonia. There is an ability to experience pleasure. You do not experience pleasure. We call it anhedonia, from the word hedonism. Okay? So, wala na. Yung kumakain ka ng cake, nag-enjoy ka, hindi mo na ma-enjoy. Yung enjoy ng sea, breeze, hindi mo na ma-enjoy. Right? And you lost interest in your work and your environment or surroundings. Very common. Ito yung palaging nandyan. No? On the case of mania naman, it's the opposite. No? Remember, in mode disorder, we're always going to the two poles. No? One pole, we call it unipolar. So we call it depression on the negative side. On the higher side, we call it mania. sometimes euphoria. Okay, but mixed, we call it bipolar. No, so I would like to emphasize this. I believe your teachers discussed this with you. Our emotions are always two-sided. No, always looking into the levels of happiness and the levels of sadness. We are supposed to be controlling our levels of emotions that way. But the problem is we stay too long on one side. We call that as unipolar disorder. So in the case of negative disorder, it could be clinical depression. And on the other side, as I mentioned to you, it could be euphoria or mania. In mania also, it's very dangerous because the tendency is that sometimes you are very violent. So you are a threat to others. In depression, the threat is actually manifested towards you, towards yourselves, at a danger to commit suicide. That's usually the problem. In mania, always take note that there is a persistent and undue happiness. You laugh all of a sudden. You are really irritable. No, in this case, you are really agitated. In this case, your self-esteem is bloated. You are overly active. Sometimes your speech is actually very rapid. And you are delusional in a way, making big plans. Although these plans, for a fact that it will not happen. See? But the most important thing that you have to take note here is that if you have mania, you could be very violent in this case. That's the thing that we have to look into with patients who do have mood disorder, particularly bipolar disorder. No, that's why we call it in bipolar disorder. They are also delusional in any way. Yeah, and they are also very, very, let's say, violent. Okay, so next one, they spend money unnecessarily, poor self-control. No, spending money unnecessarily. These are manifestations also that something big is actually going to happen to them. Maybe they do not want to. After spending their money, they may want to die eventually. We have to look out on suicide in this case. That's why, as Leah mentioned earlier today, when she asked questions about what could be the first thing that we should always take note if we take care of psychiatric patient, this is on patient safety and the safety of others. They must not be a threat to themselves and a threat to others. Remember, patients with mania may have poor self-control. They are increased socialization as opposite to a person with depression, and decreased need for sleep. Yung parang bangkwan, the most common manifestation of this yung parang nakasyabu. Yung nakasyabu, very active. If you're going to look on the anatomy of your brain, definitely napakarami ang amount ng dopamine level in the brain. So we have to control that. We have to lessen that. But eventually, it will die down. That's the reason why sinabi ko sa inyo kanina na excessive happiness is not also good. So sometimes you learn how to control this. No? That's mania. Then schizophrenia is under psychosis. A person is already out of touch with reality. This is a major psychiatric disorders. Most of the patients who are confined in the hospitals, in psychiatric hospitals, are people with schizophrenia. Sometimes they are abandoned already by the family members. No? These are characterized by the presence of psychotic symptoms, such as delusions, derailment of their thinking, and their illogicality. No, they are illogical when they think, and they're out of touch with reality. That's why they are illogical. No. Sometimes they have disturbance of perception. When you say perception, we are going to look at our five senses. You see, our sense, the thing that we are actually used to interpret our senses are called perceiving or perception. Now, in schizophrenia, may problema rito. Minsan, there is a problem with the perception using the eyes. Sometimes we call it visual hallucination. Sometimes there is perception pertaining to your auditory nerves. We call it auditory hallucination. There could be tactile hallucination. That's not very common, There is also olfactory hallucination. These are some of the things that you should know. These are the most common types of hallucinations that we have among patients with schizophrenia would always be visual, we see things, we see people, and auditory, we hear people. And these are also common among patients with mania or with bipolar disorders. So we need to watch out this. Now, the most common symptoms that we are going to observe from patients with schizophrenia are the following: inappropriate affect. Affect is a long manifestations of emotions. This is different from emotions that we have. No, then talking to self, definitely. Yeah, sometimes it's right to talk to ourselves, but make it sure that we do not show our selves to others when we talk to ourselves. Talking to self is necessary once in a while because this is what we call a self-assurance. No, this is very important in psychology. But talking to self, just because you are imagining something, you're talking to someone that is inanimate, then there is already a problem. Like in the case of taong grasa, most people who are actually having schizophrenia may not take care of themselves, particularly their personal hygiene, and they'll not be able to finish their work, definitely. And sometimes, once that we have this, they'll be out of work. They hear voices. This is auditory hallucination. Paranoid, suspiciousness, no? It's very difficult, no? You're actually going to be very suspicious about people. Others, you are thinking that they may hurt you, they may kill you, they may, spread gossip against you. It is not also healthy. And of course, you start to isolate yourselves. You remove yourself from other people. So decrease socialization. Yeah, you would like to live on your own. Then you usually have unusual and illogical thoughts. Your train of emotions is there, like thought control. There are so many things that you can actually observe here, as if you can actually control the people so better. The trains of thoughts is actually not logical anymore. There is always you use word salad. Yeah, you always can become be aggressive to other people, and again, just like in depression, you may lack interest in your surroundings in other activities. But that manifestly, the most important thing that you will discover here is that the things that they are displaying are unrealistic anymore. Like, for instance, they say that they are Superman. They say that people are controlling their thoughts. Sometimes they actually duplicate the actions of other. We call that as ecopraxia and echolalia, So we look at that as we go, no? And the categories of psychosis would be under the following. There is a problem with motor activity, like in the case of phonation. There is a problem with emotions, no? Disorder of reality and thought processes, and disorders of perception. So that's why there are problems with perceptions. In the case of motor activity, the patient may actually have mannerisms, they are hyperactive, they have stereotypes, then they have tics also, tics, and uncontrolled movement, and there is also psychomotor agitations. No, there is more time, these psychomotor agitations are uncontrolled movement of any parts of your body. No, or there could be psychomotor retardations. And the most common symptoms among severe cases of schizophrenia is catatonia. The catatonic symptoms, particularly catatonic stupor. Stupor, they assume specific position for a period of time, like raising their hands for a period for 1 day or 2 days. They will just assume that position for a long period of time. The most common position of person with depression and with people of catatonic stupor type would always be like fetal position. They use that, no? Selective muteness, sometimes they do not want to talk no matter what. Posturing, waxy flexibility. So, you can actually control their movement. Ecopraxia, yeah? Then echolalia also. Ecopraxia is they follow your movement. This is the difference with echolalia. In ecopraxia, if you move your hand, they move their hand the same way. In echolalia, when you say I am, They say, I am. They follow you. They echo you. They echo what you're going to say. Then there is ambitendency, always ambivalent feelings and negativism. No, that's what they can actually have. So when the patient is already, when you observe a patient who do have some problems with reality and they are catatonic, then you are sure that the patient may have schizophrenia. That's the reason why this is one of the basis of differential diagnosis that we have. This may not be present among patients with bipolar disorder. See? If a patient is catatonic, then 100% they are having schizophrenia, right? So disorders of emotions, we have euthymic, dysphoric, irritable, euphoric, expansive, elated. This is on the higher end, positive side. Exaltation, ecstasy, then negative side, depression, anxiety, and apathy. Now, there is disorders of affect, sometimes inappropriate. When a person requires to be sad, that means to say they need to cry, but they laugh. That's the reason why we call it inappropriate affect. No, labile emotions. So no reactions at all. They're supposed to be happy, but no reactions. Emotional incontinence, we do not know. We cannot predict how they react. And then, of course, blunted and flat. No reaction at all. Okay? That's what we have among patients with problems with emotions. Now, in thought process, we are going to look into disorders of form, disorders of stream, disorders of content, disorders of possession. I would like you to pay attention on this because surely this will appear in the examination. No? What are we going to do eventually with these cases? No? So next slide. So in disorders of perception, there are problems with how we perceive the reality as dictated by our five senses. So this can include illusions and hallucinations. You know the difference between illusions and hallucination. In illusion, the perception is different from what is supposed to be in reality. But in hallucination, you perceive something that is not there. That is actually the difference between illusions and hallucination. So like for instance, when I have a pen, you say that this pen is something else. That's an illusion. There is an object of sensation, but the way you perceive it is different. But for hallucination, you claim that there is something, but in reality, there is nothing. Just for instance, when you talk to another person in the room, you see that there is another person in the room, and that's hallucination. The reality is that there is no other person in the room. That's the difference between illusion and hallucination. Now, depending upon the sensory organ, of course, involved, hallucinations can actually be classified into 5 classifications I mentioned to you. Auditory, visual, tactile, gustatory, and olfactory. Gustatory is taste. Yeah? You taste something. Yeah? That is not there. That's not there. Okay? So, any questions so far? I think that ends our session for today. Tomorrow, I am preparing questions so that we can actually do rationalization. We try to answer some questions that might likewise be appearing in the board examinations on psychiatry. Remember, we are going to have 100 questions in this is a major part of your examination. You should know how to rationalize when you see some questions. You do not just select the best answer. Remember, when you are going to take board examination, every selection that you're going to have, you may be 20% correct because there are always 5 options there. 20% correct, that means to say you may fail. So I really would like you that when you are going to judge the question, answer a question, I would like that you are always going to think on what you learned so far. Always consider the 3 aspects, no, that you have learned. The biological, the psychological, and sociocultural. This will always be the basis of your judgment on what you need to do of patients who may actually have mental disorder. And of course, the first thing that you are always bear in mind will be the safety of the patient and safety of others. Then, looking at that, the other thing that you have to bear in mind also is that when you are going to treat psychiatric disorders, we are going to treat them according to symptoms. Like in the case of hallucination, We are going to treat the patient. We do not reinforce, but we are going to treat according to how the patient is actually telling about their hallucination. That's how we do it. We are going to treat symptomatically. That's how we do it. Okay? So I think 1.5 hours is a very good productive hour for us. No, I can actually entertain questions if you are going to ask questions. If you have some questions in mind.
So guys, now's the time to ask questions to Dr. Arnel.
Anybody can actually ask questions right now.
So,
Yep.
tanong ko lang, how would you know that the patient is like ready for recommendation with a doctor to yung yung safe na siya for functional and all?
Okay.
Magiging functional na siya within the community. How would you know as a nurse?
I got your question.
Mm-mm.
Tandaan natin to. Very important, it will appear also in your board examinations. Ang label of discharge. You are actually asking about how do we know if the patient is ready for discharge. Ganito ang pag-discharge ng pasyente. Hindi basta-basta nag-discharge ng pasyente. But in United Arab Emirates, they're always going out on lama. But technically, like in the Philippines, hindi basta-basta magre-discharge. Ganito yon. So the discharge is actually going to be recommended by board of directors in the hospital as represented by the psychiatrist. So ang psychiatrist naman is actually going to depend on the records that we are reporting. So ganito yon. So isasabihin natin yung kanilang observations, i-observe natin. So they are actually very functional already. They are very helpful to others. They are not danger to others and to themselves. We can always take that into consideration, put that in the record. Then the psychiatrist will recommend the discharge of the patient. It is not going to stop there. Since this is a psychiatric case, it will go to the board of directors. Re-reviewin nila yan before the patient is going to be discharged. That's how it works. They can overturn the decision of the psychiatrist. Pero basically, maaaring i-discharge ang pasyente pag kaya na niyang mabuhay ng sarili. They are not liabilities to others. In short, they can be functional in the society. Kaya nga gradual ang pag-treat sa kanila. Kaya nga in Malaysia, may tinatawag na halfway house. Doon muna sila o-observe. Magtatrabaho sila, makikipagsalamuha sila sa labas, makikipagsalamuha sila sa family. There is a continuous monitoring, naliligo ba sila ng tama, and then kaya na ba nilang magluto, they are exposed to sharp objects, so are they safe? Then based from that, we can actually report that, and the psychiatrist will recommend the discharge. That's how it works. Remember, always take note, the level of functionality. Yun always ang titignan natin. How they are functional. If they are very functional, alam nyo na ibig sabihin ng functional, no? Kaya ng mamuhay ng sarili. That's how it works. So, maaari ang pasyente ay pwede na i-discharge.
Doc, how long? Curious ako. Like 1 month, 2 months, 3 months?
That
Na
is,
functional sila as a patient?
yeah, that's a tricky question. How long will that be? You see? So, sa psychiatry kasi, sa mental health, napakahirap mag-decide in any possible way. Halimbawa, may mga i-discharge after 5 months of observation, bumabalik din sila. Well, we can always recommend that they can actually be discharged after a close monitoring and masasabi natin they are okay. But the problem is, after 1 month, they will come back. The tricky thing that we need to do as the psychiatric practitioners would be, number one, if we are planning to discharge the patient, makipag-coordinate tayo sa family and then community. Kasi if hindi natin alam. Usually it fails. The discharge of the patient, they come back because yung community nagkakaroon pa rin ng stigma. Yung community is, they are already branding the patient who goes to a mental hospital as if they are not fit to live in that particular community. Yun ang problema. Kaya yung mga iba, pwede na silang umuwi, pero ayaw pa nila umuwi just because they are ashamed to go because of this brand. But basically, again, as I keep on telling you, how long? It depends on the willingness of the patient to go, if they're ready. How do we assess if they are ready? If the family accepts them. Yeah, that's how it works.
Thank you, Doc. That's really good.
And of course, financial consideration also.
Yes.
Kung government yan, walang problema. Pero kung hindi, kung limbawa private hospitals, tulad ng Alain Hospital, may ward 3 sila doon, they can actually be discharged anytime they want to, as long as they can be functional. That's what's happening in UAE. Pero ang problema, bumabalik mga pasyente kasi nga branded na sila. That's the problem that we have.
Thank you po, Doc.
Questions?
Doc, sorry.
Eduardo Martin, yes.
So, Doc, regarding with the decision making sa Pilipinas for the psychiatric patient, so yung ang mag-release pa rin sa kanila is yung board director pa rin po.
That is the real setup, no? But board of directors is represented by the psychiatrist, no? Paminsan-minsan,
Okay.
you know what's actually happening. Sometimes the board of directors do not meet anymore. Shortcut. So yung psychiatrist, as long as the psychiatrist decide, it will be carried over by the board of directors. So parang okay na. And sometimes it happens that way. Pero pag itatanong kayo sa board examination, practicality, or let's say what's really happening is different from what is supposed to be happening. You know, yung cases talaga is re-review ng board of directors. Yeah, which is seldom or really happening in the Philippines. Alam mo na kung anong nangyayari doon, right? Psychiatrists discharged. Yeah, that's how it works in that. Okay. Pero
Okay,
kung sumagot tayo, we should be realistic in any way. Always ang sagot natin sa mga questions is what is supposed to be done and not what's actually being done. So there is a difference between what is supposed to be done and what is being done. Yeah.
Okay.
So like in the case of patient restraint also, what are you going to do if the patient is already very violent? Of course, definitely you have to exert some effort, some force, no? Para ma-hold mo yung pasyente, especially yung pasyente malalakas. Isn't it?
Yes.
Yeah, then eventually we are actually going to isolate them and then give them sedative para makatulog. That's what we are doing in reality. No? Supposed to be, once in a while, we have to be ideal. So yun ang tanong sa board exam palagi, what is supposed to be ideal? Yun ang gagawin natin. Yeah? Especially yung mga practice ninyo, nagtrabaho na kayo, lumabas na kayo sa kwan. Kasi paglabas natin sa ating college, idealistic pa tayo eh. Very idealistic pa tayo. Kaya nga pag kumuha tayo ng board examinations, swak na swak yung ating answer. Pero pag lumabas na tayo, especially we have worked in some hospitals already, the practice is different from what is supposed to. Isn't it? So usually when we answer, what is supposed to happen? What is supposed to? Yun dapat ang isip natin.
Thank you.
Any other questions?
Hi po, Doc.
Maan, Annalyn. Yes.
Yes, this doc is according sa patient with ESD. So,
ADHD.
yeah, yung psychiatric doctor po ba is maka-diagnose ng autism?
Usually we don't actually go to psychiatrists if we have a patient with ADHD. Psychologists will be the most appropriate person to. Because ang nangyayari, psychiatrists will always treat them with medicines. Well, in fact, if you're going to clinical psychologists like us, we can always help the patient. No, we do activities, and we do psychotherapy. In the case of diagnosis by psychiatrists, yes, they can, because there are always bases of diagnosing them using the diagnostic statistical manual. EDH stays in there. Yeah. So we use that all the time. But in the process of treatment, the best possible person to treat would be psychologist, not a psychiatrist. Because psychiatrists are not properly trained to do some psychotherapeutic interventions in any way. Usually they're trained to give medicines, that's all. That's the reality of it. Yeah.
Okay, Doc. Yeah. Thank you.
Yeah. Okay. Any
So
other
guys, do you
questions?
still have questions for Dr. Arnel before we end this presentation or end this session?
So tomorrow I'll try to present as much as possible questions, realistic questions that can be answered by us. So maybe I'll prepare around 10 to 50 questions. Then we are going to do rationalizations. Para lang natin kung paano sagutin ng mga tricky questions. Remember, very tricky questions. Tatanungin sa board examination, kung sakali, ano ang gagawin mo? Ang mga mga questions doon, katulad ng ginagawa ko dito sa mga estudyante namin. Dito, ayaw mag-isip eh. Nagme-memorize lang sila. It's not very easy to look into the answers because in test-taking psychiatry, most of the questions are situational and most of the choices are related. So we should know how to eliminate one choice, one item in the choices after another before we come up with answers. Very tricky kasi yung mga questions. Almost, alam mo na, ang sagot ay A, pero pag pumunta ka sa B, yun din ang sagot. Pag pumunta ka sa C, yun din ang sagot. The best thing that you are always going to remember is this. Choose the best answer. Sometimes there is no right answer, but the right answer that we are considering will be the best answer that you put on that situation. Ganun ang gagawin natin. Okay? Kasi sa psychiatric nursing, we are always on decision making. The psychiatric nursing practice is not a definitive practice. We are always on the hunt. We are acting like investigators, you know? Ganun yun. Sometimes our diagnosis may be different from what is supposed to be observed from the patient. So it's very difficult. And anyway. Yeah? Okay? And tomorrow, nasa bahay na ako. Kaya ngayon, nasa office na ako. Just because we do some documentations kasi the Ministry of Education will come and visit us for the accreditation of our master's program, BSN program. Hopefully, we'll come out with PhD program in the future. So, yan, ganun yun. Yeah. So tomorrow, kaya nga bukas hapon tayo because I cannot do it in the morning kasi we go to church in the morning. So usually hapon will be better. 3 o'clock, 4 o'clock, the same time. Yeah. I hope you learned something today. Yeah.
So may habol pa bang question? If not, we will end this session. I think they're okay na.
Yeah. By the way, yung aking website, you can download Diagnostic Statistical Manual 5. You can actually do that. You can go there, no? So it's in the PowerPoint. You can go there, then download the books. I also uploaded their psychiatric nursing textbook. If you want to read more about that, to increase your knowledge in psychiatric nursing, you can download also. Okay? Si Sander is share yung aking slides, di ba? So you go to my...
Naka-share na po sa kanila, Doc. Meron na silang copy.
So they can download the Diagnostic Statistical Manual 5. They can also download the book by Townsend. So that's free of use. You can actually use that, no? Okay? We call it a day? Sunday?
Thank you,
Thank you, Dr. Arnel. I think everybody is happy.
Thank you, Doctor.
Thank you po, Doc.
Salamat po.
Okay, see you tomorrow. See you tomorrow. Bye-bye.
See you, Doc.
Sige po, Doc. See you po. Sir
Doctor,
Sander,
same
thank
time
you
tayo
po.
tomorrow.
Yes,
Thank you, Doc. Thank you.
Alright, thank you, Dr. Arnel.